Every year, roughly 1 in 3 hospital admissions in Americans over 65 are connected to medication side effects. Not rare drugs. Not experimental treatments. The common ones, the ones prescribed by trusted doctors, the ones sitting in pill organizers on kitchen counters across the country. And here's what most people never hear: the drugs didn't change. The body did. After 65, something fundamental shifts in how your body handles medication, and it's not subtle. Your kidneys lose roughly 30 to 40% of their peak filtering function by the time you reach your late 60s. Your liver metabolizes drugs more slowly. Your body composition changes: more fat, less water, less lean muscle. Fat-soluble drugs accumulate in body fat. The same dose of a water-soluble drug hits your bloodstream at a higher concentration when there's less body water to dilute it. And your brain becomes measurably more sensitive to chemical interference as you age. Put all of that together, and you get this: a pill that moved through your body in 6 hours at 45 might take 12 or 14 hours at 70. Same pill. Same dose. Completely different pharmacological event inside your body. This is the science of pharmacokinetics, how the body absorbs, distributes, processes, and eliminates drugs. And here's the uncomfortable truth: most clinical trials that established standard drug doses were conducted predominantly on younger adults. The standard dose on your prescription bottle was calibrated for a body that functions very differently from one that's lived 65 or more years. That gap, between how drugs were tested and how they behave in older adults, is where the real danger lives. 5 drug categories sit at the center of it. And the first one has been in medicine cabinets for decades. Benzodiazepines. You know them by their brand names: Xanax, Valium, Ativan, Klonopin. Prescribed for anxiety, panic attacks, sleep problems, and muscle spasms. They work genuinely well, which is precisely what makes them easy to overlook. In a 35-year-old, a benzodiazepine enters the bloodstream, reduces neural excitability, does its job, and clears out within a few hours. In a 70-year-old, that clearance time can double, sometimes triple. The drug remains pharmacologically active in the body long after the person believes it has worn off. Think about what that means in practice. A 69-year-old takes half a dose of Ativan before bed. Her doctor prescribed it years ago for anxiety, and she only uses it occasionally. She wakes the next morning feeling completely normal. But her balance is still compromised. Her reaction time is still slowed. She walks to the bathroom at 2 in the morning and she falls. She fractures her hip. That fracture, statistically, becomes one of the most dangerous medical events an older adult can experience. Hip fractures carry a 1-year mortality rate of approximately 25%. Research published in the British Medical Journal confirmed that benzodiazepine use in older adults is associated with a dramatically elevated risk of hip fractures and fall-related injuries. But the cognitive risk is where it gets worse. Long-term use in people over 65 has been repeatedly linked to memory impairment, executive dysfunction, and elevated dementia risk, decline that, to outside observers, can look like early Alzheimer's when the actual driver is the medication. And because the prescription was written years ago, and because the patient says they're fine, nobody revisited the conversation. That conversation is worth having today. NSAIDs. From benzodiazepines, a drug many people assume requires caution, we move to something most people would never think twice about. Ibuprofen. Naproxen. Advil. Aleve. Available right next to the checkout counter. These drugs appear by name on the Beers criteria, a list updated regularly by the American Geriatric Society identifying medications that are potentially inappropriate for adults over 65. NSAIDs are explicitly flagged. Here's why. NSAIDs block certain enzymes, and one consequence of that blockade is reduced blood flow to the kidneys. In a 30-year-old with fully functioning kidneys, this temporary reduction isn't a problem, the kidneys adapt. In a 67-year-old whose kidneys are already filtering at reduced capacity, that same reduction can tip the balance into acute kidney injury. Older adults are also frequently dehydrated, not by choice, but because the brain's thirst signaling weakens with age. You're not as reliably thirsty as you used to be. Take an NSAID when mildly dehydrated, with kidneys already running below capacity, and the risk compounds quickly. Even a short course of NSAIDs in elderly patients can produce rapid, significant decline in kidney function. Then there's the gastrointestinal tract. NSAIDs damage the protective lining of the stomach and intestine, and research shows the risk of GI bleeding is 2 to 3 times higher in people over 65. That bleeding can be silent, no obvious pain, just slow blood loss that eventually presents as dangerous anemia or a sudden crisis. Safer options exist. Acetaminophen, at appropriate doses, handles most mild to moderate pain without kidney or GI risk. Topical anti-inflammatory gels deliver effects locally, without systemic exposure. These alternatives are not obscure. Most people are still reaching for Advil out of habit, because nobody told them the risk calculus had changed. Anticholinergics. This is the category that catches people most off guard, because anticholinergic drugs rarely announce themselves. They come disguised as allergy relief, motion sickness tablets, bladder control medications, and even some antidepressants. The most common example is Benadryl. Diphenhydramine, the antihistamine that's been in American households since the 1940s, also sold as a sleep aid under names like Unisom and ZZ-Quil. Here's what it's actually doing in the brain of someone over 65. Anticholinergic drugs block acetylcholine, a neurotransmitter central to memory formation, attention, and muscle coordination. In younger adults, the brain has enough acetylcholine reserve to compensate. In older adults, that reserve is naturally lower. Block it further with medication, and the impact is immediate and sharp: confusion, blurred vision, dry mouth, constipation, urinary retention, a kind of mental fog that families routinely mistake for early dementia. Doctors have a name for it: anticholinergic toxicity, and it gets misdiagnosed constantly. The long-term picture is more troubling still. A landmark study in JAMA Internal Medicine followed over 3,000 older adults for 7 years. Those with the highest cumulative exposure to anticholinergic medications had a 54% higher risk of developing dementia. This finding has been replicated across multiple cohorts in different countries. And the most common source of that exposure isn't some obscure prescription drug. It's the Benadryl in the kitchen cabinet. Aggressive blood pressure management. This one requires careful framing, because controlling blood pressure is critically important. Unmanaged hypertension remains a leading cause of stroke and heart disease, and nothing in the research changes that. What the research does question is the target. For decades, the medical consensus was, lower is better. That logic made sense for average adults. But a major study published in JAMA found that in adults over 75, aggressively pushing blood pressure below 130 systolic was associated with higher rates of falls, fainting episodes, and in some analyses, higher overall mortality, compared to a more moderate target. Here's the biology. After decades of elevated pressure, the cardiovascular system in an older adult adapts. Blood vessels stiffen. Drop the pressure too aggressively and the brain, which requires consistent blood flow, doesn't get what it needs. The result is orthostatic hypotension: stand up and feel dizzy, bend over and the room tilts, or lose consciousness completely and fall. This is not an argument against treating blood pressure. It's an argument for asking a specific question: what is my target, and is it calibrated to my age, my fall risk, my overall medication load? These are reasonable questions. If your doctor hasn't raised them, you are allowed to. Proton pump inhibitors. Omeprazole. Lansoprazole. Prilosec. Nexium. Among the most widely used drug classes in the country. They were designed for short-term use, weeks, occasionally months. Because they eliminate symptoms so completely, people stay on them for years, sometimes decades, without ever revisiting the necessity. Stomach acid is not only a problem, it's also a tool. Your body uses it to absorb calcium, magnesium, and vitamin B12. Suppress acid production consistently and long-term, and the body loses its ability to extract these nutrients from food, regardless of diet quality or supplementation. In older adults, calcium absorption is already declining naturally. Magnesium and B12 status are already vulnerable. A study published in Osteoporosis International linked long-term PPI use to a significantly elevated risk of hip fractures, because chronic calcium malabsorption weakens bone density over time. A separate body of research ties chronic PPI use to measurably higher rates of B12 deficiency in elderly patients, with consequences including peripheral neuropathy, memory changes, and persistent fatigue. Stopping abruptly is not the answer. Acid rebound can be severe. The answer is a conversation. Is this dose still necessary? Can we step down? Are my nutrient levels being monitored? So what do you do with all of this? Start with a full medication review. Bring every pill you take, prescription and over-the-counter, to your doctor or pharmacist and ask for an age-specific evaluation. Ask directly, is anything I'm taking on the Beers criteria? The list is publicly available and updated regularly. You have every right to know if something you're taking is flagged. Never stop a medication abruptly without guidance, particularly benzodiazepines and blood pressure medications, where stopping suddenly can trigger dangerous withdrawal or rebound effects. Ask about alternatives. For most of the drugs discussed here, safer options exist that manage the same symptoms with less risk in older adults. The option often exists. The question is whether anyone has introduced it. And take unexplained symptoms seriously. Persistent confusion, dizziness, fatigue, or mental fog that feels new, that isn't necessarily aging. That might be pharmacology. Write it down. Bring it to your next appointment. The body at 68 is not the body at 45. Not weaker, different. It processes medication differently, and the science now recognizes that clearly. The question isn't whether this is true. The question is whether your care has caught up.